Okay, so now we will see the coarctation of iota. So I've been posting all the pictures, so that should be more colorful for you to understand. Okay, so when we talk about coarctation of iota, then seeing the description that is given in your book, you can go through what I have typed there. The definition says that it's a narrowing of the iota which arises from the heart. Okay, and the picture also I have posted, that you can see where there is a narrowing and then how the surgical correction has been done. You can see the repair also in the same picture. So this is a congenital anomaly again, which occurs with other disorders. Okay, then coming on to clinical manifestation to your book, this there can be high blood pressure. The child will exhibit high blood pressure, then bounding pulse will be there in the arm, weak or absent femoral pulse also will be there. When we check the femoral pulse, we will not be able to feel the femoral pulse. Then cool lower extremities with low blood pressure. Because of the blood supply, there is low blood pressure, and because of which it also leads to chillness in the lower extremities. Signs of CHF, okay, congestive heart failure. Mostly in every condition we have seen that it leads to CHF. And older children may experience dizziness, headache, fainting. Okay, next coming to surgical treatment. So what is the surgical treatment here? Surgical repair is treatment choice for infants younger than 6 months of age. So if the child is 6 months of age, below that only surgical repair only can be done. Non-surgical treatment, balloon angioplasty, like for how we balloon angioplasty is also used to dilate the coronary artery, right, in case if there is an occlusion. So same like that, balloon angioplasty is being performed as primary intervention for coarctation of iota in older infants and children. So in adolescents, stents may be placed in the aorta to maintain patency, so that again it does not narrow. Okay, so that is all about coarctation of aorta. Next condition, we will move on to PDA, patent ductus arteriosus. So what is this? As we have already seen, patent ductus arteriosus, soon after the child is born, it is very normal for a newborn to have. So it should close within few weeks of life. If it is not closing, then it will lead to a condition called as patent ductus arteriosus. Okay, so failure of the fetal ductal arteriosus, that is artery connecting the aorta and pulmonary artery, you can see in the colorful picture, to close within the first week of life. The continued patency of this vessel allows blood flow from the higher pressure aorta to the lower pressure pulmonary artery. So this opening which is found between the aorta and the pulmonary artery should close. After birth, if it is still not closing, what happens? There is a shunting of the blood that happens from the high blood pressure aorta to the lower blood pressure, that is where the blood is low, pulmonary artery, and which causes to left to right shunt. Okay, so what are the clinical manifestation in this condition? Patient may be asymptomatic and show CHF. There is characteristics machinery like murmur sound will be there, and then because the gushing of the blood happens, then CHF will be there, a widened pulse pressure. So what is the pulse pressure? It is the difference between the systolic and diastolic blood pressure. So it becomes widened. Okay, so it becomes more than 40 mm of Hg. Then patient at risk for bacterial endocarditis. Okay, so it is also condition where the child can end up having bacterial endocarditis, same like VST we have seen. Okay, then medical management. What is the medical management? Administration of indomethacin will be given, that is prostaglandin inhibitor. Has proved successful in closing a patent ductus in premature infants and some newborns. Okay, so they will give this medication which is the prostaglandin inhibitor. So this has proved successful in closing so when we give this medicine, automatically it closes the PDA in immature infants, okay, and some newborns. So surgical treatment, if we see, surgical division or ligation of the patent vessel is performed via left thoracotomy. So left side of the chest they will open and they will try to suture it if it is not closing by itself. Okay, and then you have a newer technique. So what is that newer technique? It is almost like a video assist, like a laparoscopy. Okay, so video assisted thoracoscopic surgery, a thoracoscope and instrument, okay, like a thoracoscope will be inserted into 3 small incisions, same like laparoscopy, how we enter into the laparotomy in the abdomen. So here thorax region they will make incision, through that the instrument will be inserted and that will be visualized in the video outside. Okay, so that's why we call that as video assisted thoracoscopic surgery. Okay, and on the left side of the chest to place a clip on the ductus. So they will try to put a clip and they will try to close it. So non-surgical treatment, it coils to occlude the PDA are placed in the catheterization laboratory in many centers. So through cardiac catheterization, they will try to close it. Okay, they will try to coil it. That is the non-surgical treatment. Okay, so we have done with various cardiac anomalies. So that is done. So please go through all the diagrams, and I have posted few definitions because that is easy for you to understand than the descriptions. So please see those colorful pictures, and then you can also go through all the the definitions which I have posted, so that is easy, so you can refer that. Okay, next going to orthopedic abnormalities. So here mainly it is a clubfoot which is congenitally anomaly. So during birth itself, we will see that the baby will be having musculoskeletal problem, mostly related with the bones on the foot. So those conditions are called as clubfoot. Definition: it is a deformity of foot twisted inward. So you can see in the pictures how the foot is actually inwardly it is rotated. Classification: you have talipus equinovarus, second talipus calcaneovalgus, talipus equinus is the third, and fourth one is the talipus calcaneovarus. Okay, I repeat, first one is talipus equinovarus, second one is talipus calcaneovalgus, third one is talipus equinus, fourth one is talipus calcaneovarus. Okay, now talking about talipus equinovarus. So foot plantar flexion deviated medially, heel is elevated. So here you can see, right? So heel is elevated in the here in the diagram you can see equinovarus is the D picture. Okay, so heel is little elevated, and foot plantar flexion. This is the plantar flexion. So you can see a elevation over only the heel. Okay, deviated medially, so towards the center of the body. Okay, and then heel is elevated. Talipus calcaneovalgus. So you can see the B picture. So foot is dorsiflexed. Okay, so this is dorsiflexion, right? So it goes like this up. Okay, so foot is dorsiflexed and deviates laterally. Okay, it goes at the side. You can see that. Okay, at the side, and it is lifted. So this is the second type. Okay, that is the talipus calcaneovalgus or valgus. Okay, third one is talipus calcaneovarus. So in the diagram it is the first one. It is just opposite to the second type. Foot is dorsiflexed and then heel is elevated. Heel gets elevated. Okay, foot is dorsiflexed. Both the condition, foot is dorsiflexed, but here we will see that heel gets elevated. Okay, and then fourth one is talipus equinus. You have to by heart all this and remember. Please remember the diagram also. Okay, so plantar flexion, this is the fourth type, and you can see in the picture E. Okay, plantar flexion happens in which the toes are lower than the heel. So like this. Okay, so the heel goes down, plantar flexion, and then heel goes down. So the toes are lower than the heel. Okay, so the heel is lifted up. You can see that in the diagram. So terminology: varus means bending inward. So we call varus whenever the foot is bending inwardly, and valgus is bending outwardly. Equinus's toes are lower than the heel. Calcaneus toes are higher than the heel. So with this you should be able to understand. Okay, causes. So exact cause of clubfoot is not known. Familiar tendency means mostly hereditary, and it is intrauterine positioning. Okay, so mother has to take care of the positioning properly, otherwise it can lead to clubfoot in the children, and the way the baby also is positioned intrauterinely is very, very important. Diagnosis: first neonatal examination at birth. Okay, so when the baby is born itself, when we do the physical examination, we will get to know if the baby has got clubfoot. And then family history we can collect, x-ray of the affected foot can be taken, and we can also analyze whether it is talipus equinovarus, talipus calcaneovalgus, or talipus calcaneovarus, talipus equinus. All this can be found out. Now talking about the management: non-surgical Serial manipulation followed by immobilization in plaster cast. They will apply cast and they will try to make it straight. Corrective shoes with or without splint or bars can be given. So you can actually, you would have seen some children wearing with the bars for the support at the side. Okay, so that kind of shoes can be given, which are corrective shoes with splints or bars. It can be with the bars or without the bars. Then surgical management, we can do the surgery only when the baby is of month of 4 to 9 months. Then correction of bony deformity. So the bone can be corrected through the surgery. Post-operative immobilization to be done, cast for 12 weeks followed by corrective shoes. So you can see here how they have abducted, abduction of the foot of the hip is done, so that they do not cross with each other. So immobilization to be done, the baby should not be mobilized, and then proper positioning has to be done for 12 weeks. Okay, so almost it is like 4 for 8 3 months. Okay, immobilization. Then nursing management, so we have to explain the various treatment and then reassure the patient. They will be very much psychologically upset. Reassure, give them psychological support, encourage parents in involving care. Allow them to do care, morning care, feeding. Okay, like that you can allow them, combing the hair for the baby. Assess fit of cast. Then we'll also see if the cast is fitting properly. Assess fit of cast, splint, braces or special shoes for the baby. And then assess pressure on the, then we should also see if it is causing pressure over the skin. It can lead to ulcers. Okay, assess pressure on skin by cast. You will see redness, excoriation, peeling of the skin, full odor, foul odor, okay, bad smell underneath the cast that we have to assess, because already if the wound has formed, then it can lead to foul smell. Assess for signs of discomfort. If any of these is happening, the child will cry, irritability will be there, poor feeding will be there because of pain. So that has to be assessed, why the baby is crying, why the baby is not eating properly, feeding properly. Then check with the cast. Okay, then administer analgesic. So if severe pain is there, we have to give analgesic as per the physician's order for 24 to 48 hours after surgery. Provide comfort measures such as soft music, okay, rocking, pacifiers. Allow the mother to sit on the cot, put the baby on the mother's, give them the cloth. Now how PP personal protective equipment are there, like that gowns will be there in the hospital. So you can give gowns to the mother, so that after you give the gown, you make the mother to sit on the cot of the baby and place the baby over the mother for comfort. So when baby sees mother, baby will be not scared, the baby will not cry, because it is only 4 to 6 or 8 months, right? So we have to make sure, or older children also, allow the mother. Then assess neurovascular status like color, warmth, sensation, pain, pulse, presence of pain. All this has to be assessed, because if the cast is compressing the nerve, okay, then we can make out, okay, for that reason. Then elevate the extremity, surgical area has to be elevated. Then stimulate movement of toes to promote circulation. Then teach parents use of braces, how to use the brace, corrective device, how to remove it, how to position it has to be taught. Then explain the importance of follow-up, coming and showing to the hospital even after the discharge. So when we talk about stimulate movement of toes to promote circulation, is passive exercises, that you can give to the patient, to the child. You can teach some other also. Okay, next, developmental abnormalities of extremities. So now club foot is done. We will go to the extremities. Okay, so congenital malformation includes polydactyly, syndactyly, reduction deformities. So polydactyly is, it is a developmental anomaly. There are numerary digits, fingers or toes, more than 10 fingers or toes. So if it is more than 5 itself, we call that as polydactyly, more fingers, like Hrithik Roshan has, right? So that is common. If there are skin tags, if any skin tags are there, it should be removed. Surgically remove the extra digits if it is harmful. Otherwise, people you can see with 6 or 7, they still manage. But walking is difficult, means surgical treatment is required, then we have to do that. Syndactyly is nothing but fusion, like a web. It will be fused together, like frog, when you see how it is webbed together. This is persistence of webbing between adjacent digits, so they are attached with each other. There wouldn't be no space, it will all be joined together. Based on the attachment between digits, movement is limited, surgical correction has to be done. Okay, and then you can see in the picture. Okay, limb deficiency. Next we'll go to limb deficiency. So I think limb deficiency we can continue in the next video. Okay.